campus of Stanford University.
People are worried about data. They're worried about their privacy and their security. They should be. We need secure systems.
This is the future of everything.
But we can't have a system that closes that data off. It is too rich of a source of inspiration, innovation, and discovery for new things in medicine.
With your host, Russ Altman.
Today on The Future of Everything, the future of radiation therapy. So cancer, we all don't like cancer, and it continues to be a major problem. We've heard about great advances, but globally there are still millions of cancer deaths every year. So despite these advances, we still need more and better treatments. And when you think about cancer therapy, a lot of things come to mind immediately. One thing is chemotherapy, the dreaded word, chemotherapy. These are very toxic drugs that try to kill the cancer and usually have very big toxic side effects on the patients. You also think of surgery. Let's go in and remove that cancer. But we know that the surgery doesn't always work because there might be little bits of cancer that the surgeon doesn't see or that are distant from the primary cancer. And so surgery also is not always working. And then the third thing that some people think about and that we're going to be talking about today is radiation therapy. The idea is that radiation, I'm talking about X-rays, like radiation from the atomic bomb or from linear accelerators that can create these X-rays, are harmful to cells. And they cause damage to the DNA and other cellular processes. The cells cannot recover, and especially if you're a rapidly dividing cell that needs to make copies of your DNA in order to divide, this damage can be lethal, and then the cancer cells die. That's the theory. And we often use radiation therapy in combination with chemotherapy and surgery. And anybody who knows a relative or a friend that has had cancer knows that they might go through a series of treatments involving all three of these. In particular, cancer of the lung is a very important target for radiation therapy because of the difficulty of doing some of those surgeries, the difficulty of getting high levels of chemicals into the lung. Radiation therapy has a really clear and important role there, among others. It has its benefits. There's no surgery, no extra surgery. There's no pills. You can focus the radiation, at least that's what people are trying to do, and you can kill the cancer in a very, very specific way. Dr. Bill Liu is a professor of radiation oncology, radiation therapy at Stanford University, and his research is devoted to improving the utility and uses of radiation in cancer therapy and even in other diseases. Bill, can radiation therapy cure cancer, or is it always going to be limiting the disease without completely removing it?
Thanks, Russ. I'm really excited to be here. I appreciate the invitation. So I think your introduction is right on target. I think what many people don't realize is that radiation is, in fact, one of the pillars of cancer treatment, along with other treatments like surgery and drug therapy, and that includes chemotherapy and some of the newer approaches we have with molecular targeted drugs and immunotherapy.
I didn't mention all of the new systems that are using the immune system to combat the cancer.
And radiation plays into that as well, as it turns out. But absolutely, radiation is used today in the United States at some point in the course of therapy for about 2/3 of patients with cancer.
So it's not rare at all.
So it's not rare at all. And in fact, in the majority of those cases, it is with the intent to cure. In other words, the goal of the treatment is to try to eliminate the cancer. And so, yes, absolutely, radiation is an important part of curative treatment of cancer.
So what are the frontiers? I mean, I've read stories about in the old days they would literally take a radioactive block of like radium and just stick it near the patient's chest wall, hoping that those rays would kill the cancer. And of course, they did huge damage to the skin and to the underlying tissue. Where are we now in terms of being very precise in the delivery of that radiation?
Yeah, so with the techniques that we have now, we are much better targeted with radiation. In other words, we're able to create a pretty exquisite 3D sculpting of radiation doses. And so in that way, we're able to accomplish, one of the key things that is needed for all cancer therapy. It's a big word, but the big word is therapeutic index. And what that means is being able to eliminate the cancer without causing too much collateral damage. And that's a key principle, regardless of the treatment. It turns out that what makes cancer incurable in those cases that it is when the what it takes to eliminate the cancer is more than what the patient can tolerate.
Yes.
And so it doesn't matter if it's a drug or if it's surgery or if radiation. Basically, I can give enough radiation to eliminate a cancer. That's actually not a fundamental problem. The fundamental problem is when the patient is not able to tolerate that, then we're really limited.
So tell me a little bit about how we get this precision. You said that you can even do like a 3D sculpture, and I know in some of your papers you even refer to 4-dimensional. So tell me about 3D, and then maybe we can move to 4D in terms of what are our capabilities now and how does it actually work?
Yeah, absolutely. So there's different ways of delivering radiation, but there's some common principles to all of them. And the most common type of radiation we use is high-energy X-rays.
Okay.
And the way that we create 3D sculpting of radiation doses to create focusing of the radiation is by coming in from multiple different directions. And where radiation beams cross, the dose adds up. And
so you have a bunch of maybe not so strong X-rays, but there's a lot of them coming into this point.
That's right.
And so they add up so that the surrounding tissue gets a little bit, but that one point where it's all focused gets a lot.
Exactly. And we are able now to guide that precisely with the better imaging that we have. So CT scanning, PET scanning, MRI, all of those we're able to incorporate to get the best picture of where's the cancer, where are the normal tissues that we want to spare, how do we kind of create that dose sculpting.
Yes. So now let me ask, when you use these images, CTs, MRIs, are you doing it before the treatment or are you doing it during the treatment in order to watch the effects as it's happening? Perhaps I'm just making that up.
Yeah, absolutely. So it's both. So we use it before the treatment in order to plan it. So we identify what's the area that needs to be treated, where's the tumor in relationship to the normal organs, and create that plan of very sculpted treatment. And then during the treatment, we also use imaging. And up till now, the imaging that we can use during treatment is a little bit more limited than what we have,
Right.
for our diagnosis. But it allows us to see, for example, whether we're on target and is the radiation going where we want it to go.
So yeah, this is great. This is great. And so the 4D, so obviously 3D is the shape of the tumor, and you want to match that as closely as possible. And then is the 4D over time, I would presume?
That's right, yeah.
And is it the time over many weeks and months while the patient is getting the treatments, or do you mean the time during the delivery of the X-rays?
Again,
both?
it's both. And so I think what people may realize if you think about it a little bit, right? During the treatment, every part of the body moves all the time. Some parts move more than others. So, for example, when I'm treating a lung tumor, a patient is breathing.
We do have to breathe, yes.
Yeah. And so the people are breathing, organs move, lungs and other parts of the body move. So we're always treating moving targets. And that's where the 4D comes in, is understanding what motion is going on and how do you compensate
And then
for
you
it.
can adjust so that even if you had an initial plan, stuff happens and you might need to, in midstream, adjust how you're delivering the X-rays.
That's right.
This is The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Bill Liu about frontiers of radiation therapy and the opportunities going forward. So many things to ask, but let's talk about timing. We talked about time, the fourth dimension. The traditional story about radiation therapy is often a patient going in on a regular basis over weeks or months, staying for quite a long time in a very rigid position while you guys deliver the radiation. But I understand that there's been some breakthroughs recently where the treatment times have been getting much shorter, and I wanted to ask about what's the source of those innovations, and is it having a positive impact on the patient experience? Because having cancer is terrible as it is, but having to go every day to a clinic and spend 2 or 3 hours in a rigid position can't be fun.
Yeah, absolutely. So there's basically developments over time that have given us insights into the new breakthrough that I hope we'll be touching on, which is the phaser technology that we're working on.
Oh my goodness, this sounds like Star Trek.
Absolutely, yeah.
Phaser. So that's a real thing. So tell me about phasers.
Sure. Well, so phaser it stands for a mouthful. The acronym is for pluridirectional high energy agile scanning electronic radiotherapy.
There you go.
Yeah.
Phaser.
But to be honest, the motivation for that comes from the fact that, probably like you and others of our listeners, I'm a sci-fi nerd, right? And I was influenced by Star Trek.
Of course. Is that what phaser stands for on Star Trek?
Good question. That's something we need to find out. Yeah, but growing up watching Star Trek, that was the future of medicine, right?
Yes.
In fact, the future of everything.
Exactly.
Right?
Star Trek was filled with medical things. You remember the doctor had that little thing that they put the scanner that figured everything out. I would love to have one of those.
The tricorder.
Thank you, tricorder. So what is the phaser technology?
Right. So we were talking about time and treating moving targets, right? And so a lot of the work that I've done together with my colleagues over the years is implement technologies in the clinic to compensate for motion. We call it motion management.
Right.
All kinds of tricks like turning on the radiation beam synchronized with the breathing cycle, or following tumors around with the radiation beam. Very complicated things that we're now able to do on a routine basis, but it's hard to do right, easy to do wrong, very hard to translate out into the rest of the world.
Yeah, I imagine this involves maybe robotics and artificial intelligence type technologies,
Correct,
and you don't have to just get it to work in your clinic and in your lab, but you have to figure out how do I export this so that everybody can benefit from it.
Exactly.
So the phaser technology this very intelligent tracking of the tumor and deciding when to send the beam. Is it also more intense beams?
Yeah.
Is that how we get a time shortening for the treatments?
Right. So all of those strategies that we've developed in the past have been based on the fundamental assumption that it takes longer to give the radiation treatment than it does for the body to move. But over time, as we've implemented these various technologies, we've sort of realized that the treatment times, we've successfully decreased gradually. So when we first started doing this in the early 2000s to give a big, focused dose of radiation using the new technologies of the time, maybe 3 hours, 2 to 3 hours that the patient would be on the table getting treated. Now we do those similar treatments in about 3 minutes.
That's
a huge speed
difference.
up, but still a long time compared to the motion in the body. But the insight that came from that is, what if we flipped the problem around? What if the treatment was done so fast, like in a flash, like flash photography, that all the motion is frozen? Mm-hmm. Then that's a fundamental solution to this motion problem that gives us the ultimate precision.
Yes.
And that leads
makes
to
sense.
therapeutic index, because if we're able to treat more precisely with less slop, less spillage of radiation dose into normal tissues, that gives us that benefit of being able to kill the cancer and cause less collateral damage.
This is The Future of Everything. I'm Russ Altman speaking with Dr. Bill Liu about the advances in radiation therapy, and we're now talking about phasers and flash treatments. So flash sounds like a great analogy to just imagine what it's like. And we all know that the thing about flash photography is it's extremely bright. So yes, it captures our motion, but for that, several milliseconds, we're almost rendered incapable of doing anything else because of the overwhelming light. So is there an analogy in the treatment? So first of all, it must be very stressful for you to turn on such a bright beam, even if it's for a short period of time, that the first time you do that, it must be very stressful, I would imagine, because if you've overexposed, so to speak, the patient, or if you've missed the target, you might be doing a lot of damage to the wrong part of the body. So how do you even begin to test these technologies to the point where you're comfortable using them in patients?
Right. Well, so one key part is integrating something that we've been doing for a good period of time now, which is that image guidance aspect of it, right? So it's very important to have a clear picture of what's going on in the patient's body so that the beam is turned on at exactly the right place and the right time.
It's like you're a marksman.
Yeah,
you're
exactly.
kind of when we have it in the crosshairs, press the button.
That's right. Yeah. And so, so some of those imaging technologies we already use to some extent. In fact, the way it works right now is that even though our radiation treatments aren't so fast, right? We line everything up perfectly. We hit go on the radiation. The imaging that we have right on the table is a little bit limited. And so even now, we're not seeing everything all the time, as we're treating. But if you have fast enough radiation where you can get a clear picture right at the beginning, right when you're about to fire, and then everything's lined up and you go, that's actually got the potential to be more accurate than what we do now.
Yes.
And all the motion's frozen. But the really exciting thing that we're discovering, and this is now in laboratory research, we're developing the technology to do this very fast flash treatment in humans. But using some existing technologies, we're able to test this in very small patients like mice. Okay? And what we found is...
Who can be given a range of cancers that can be then used as test grounds.
Right. And what we found preliminarily...
And even a big tumor, forgive me,
Sure,
but even a big tumor in a mouse is going to be a little tumor in a human.
Exactly.
So if you can get good with that, you can imagine it being very reassuring.
That's
they also are not very good at holding their breath on purpose for you.
Right. And so there, the question is not even the precision part, right, but just what's the fundamental biology that happens when very fast treatment is given. And what we and a few other labs around the world have started to see is that when the radiation is given in a flash, we see equal or better tumor killing, but much better normal tissue protection than with the conventional speed of radiation.
So this is very interesting. So you're saying that the biological response to the radiation actually might be different based on if it gets a lot in a short time versus a little bit over a long time. And then you're telling me also that this is actually kind of good news that for whatever reason, normal tissues seem to be able to withstand this high flash a little bit better than the cancer tissues. Do we understand why that happens?
That's a very active area of research right now. So we're just at the beginning of trying to understand that. But what we have seen is this consistent phenomenon now across multiple labs and even in a few different species of animals that this effect is occurring. And if that translates to humans, that's a huge breakthrough.
So speaking of the biology, let me ask you about resistance. Everybody knows that in chemotherapy, the big thing that you worry about is that you're going to become resistant to the chemotherapy. It's not going to work anymore. The cells stop dying because they figure out a way around it. Is resistance a thing in radiation therapy?
To a much less extent, because radiation cuts across many more molecular pathways than drugs that may work on a few molecular pathways. So the cancer cells can have different sensitivities to radiation, but resistance is still much less of an issue with radiation than with the drug therapy.
So that's quite good news.
Yeah.
This is The Future of Everything. I'm Russ Altman. More with Dr. Bill Liu about radiation therapy and its future next on Sirius XM Insight 121.
From the campus of Stanford University.
People are worried about data. They're worried about their privacy and their security. They should be. We need secure systems.
This is the future of everything.
But we can't have a system that closes that data off. It is too rich of a source of inspiration, innovation, and discovery for new things in medicine.
With your host, Russ Altman.
Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Bill Liu about radiation therapy, its applications, and its future. So, Bill, one of the really fascinating things in preparing for our conversation was the idea that radiation therapy might actually be useful for things other than cancer. And I think you've kind of led in some areas. So what would be the theory of using radiation for other diseases?
Right. Well, so radiation in cancer is used, we think, primarily to kill cancer cells. It actually has a lot of other biological effects that can contribute to that, it's much more complicated than that. But some of the effects that are not directly related to cell killing, it may modify the function or response of cells, scar tissue formation, or changes in electrical conductivity of conducting cells.
Yes.
And so some of the applications, where we've looked at diseases that are potentially treated by surgery, but in patients who maybe cannot tolerate surgery because they have, it's too dangerous for them.
Right. Sometimes you're just not a surgical candidate and the surgeon says, I can't operate on this person.
Right. And so a couple of the applications that have emerged that in clinical studies is, for example, patients who have bad emphysema of the lungs, a portion of their lung is not working because it's basically a big air bubble.
That's right. So all the fine structure of the lung has been damaged and removed, and so they don't have a surface area for exchanging oxygen with their bloodstream.
Exactly. And one of the treatments for severe emphysema is, in fact, to remove those non-functioning parts of the lung so the other parts can work better.
Yes.
And we found preliminary evidence, and we're doing a clinical trial now, where we use very focused radiation to
which we know you know how to do from our previous part of our discussion.
Right. To create an area of basically like scarring to shrink down the portion of the emphysema lung.
Yes. It kind of pulls together all of that useless tissue and lets the other tissue expand and do its thing.
Correct. Yeah. Yeah.
So where is this in development? Is this a brand new idea, or are you actually doing some trials? Where are we in the research pipeline?
So it's it has roots that are quite old, but we actually have a current clinical trial that's ongoing that's run in collaboration with Joe Schrager, who leads our thoracic surgery group here.
So is it possible that this would wind up being even better than surgery, and that for even people who could tolerate the surgery, they might elect to do this instead? Because, I mean, just thinking about it, if you told me that I could either go on the surgical table or go to the radiation therapy suite and have some, zap my lungs. So I guess it's too early, or do we have any?
Yeah, it's still very early days, but I think the way that we've seen these sorts of things evolve is that it's not an either or. It's not one replacing the other, but what it is it allows us to individualize for a given patient, expanding the options and what might be better, depending on what their risk factors are. And so it allows us to kind of tailor the treatments better if we have more options.
So I'm struck, that's very exciting, and people, and emphysema is very different from cancer, and so it's fun to think about novel uses of these technologies. And I did want to just briefly ask you about the technologies. Like, what does your laboratory look like? What are the kinds of work that your scientists in your lab, the technicians, the students, the postdoctoral fellows, what does it look like?
Well, for one thing, it's very multidisciplinary because it pulls in collaborators from a lot of different areas. Physics, engineering, biology, for example, the core linear accelerator research that we're doing for Phaser is being done led by my colleague Sami Tantawi at SLAC National Accelerator Lab.
So SLAC, for those who are not familiar, it used to stand for Stanford Linear Accelerator, but I think now it just stands for SLAC, and it's a big physical facility in the Bay Area with I think a 1 or 2 mile long tunnel that accelerates these particles to very high energies.
Exactly.
And so they're using this for medical research because everybody thinks of it as kind of energetics and nuclear research, but this is for medicine as well.
Well, it turns out that pushing the limits of that technology to study very high energy physics has other applications and translates into the medical technology as well, and that's what we're capitalizing on in this collaboration.
And I would guess that you have people who are essentially robotics experts as well in terms of this tracking and moving the beams. Is that true?
Well, in this particular incarnation, because of the speed, we actually want to eliminate all the mechanical moving parts. So it's all done electronically.
No robots.
Yeah.
This is the future of everything. I'm Russ Altman, and I'm speaking with Bill Liu about radiation therapy. I wanted to kind of also ask you about, okay, now you do this discovery, you get these amazing new technologies. There's a responsibility to get it out into the world. And how do you do that? And I can imagine that there's one issue getting it out in the U.S., where you're based. But I imagine that there's another issue and set of opportunities with getting it even more broadly around the world. How do you even think about that?
Yeah, absolutely. Well, the major problem that we face in cancer is that about half of the patients in the world today, despite the fact that radiation is such an important treatment, about half of patients have no access at all for technological and logistical reasons.
Whereas they could definitely benefit.
Correct. Yeah, so that means that millions of patients who could potentially be receiving curative cancer therapy are getting treated purely palliatively. And so that's a huge tragedy that kind of it's an emergency of our day here and now.
Yes.
And so if whatever revolutions that we come up with in technology, if it's going to impact that, it needs to be something that can be practical in the sense of it has to be compact. It has to be economical. It has to be reliable. It has to be clinically efficient. And so those are kind of core design principles that we've kept in mind from the very beginning when thinking about the phaser technology, because we don't want to create a solution that everyone in the world has to come here to get.
Right.
That would be great. But
Keep
it's
you
going
busy.
It's going to have limited impact, right? And so that's been a core principle from the beginning.
So that is a really fascinating problem because, of course, one of the things that comes to mind is it has to be robust. You're working in a very high-end medical facility, but the people who have these 50% of people with cancer around the world, many of them are living in very harsh conditions in villages and whatnot. And we have to figure out how to get these machines and have them be robust and well-powered and safe. So is this something you do as a side project, or are there people who are devoted to this kind of robustification, a word that I just made up, of these technologies? Like, whose problem is that?
So it's a problem that we're tackling from the very beginning. So not only do we want to increase the performance of the technology, but it has to be robust as well. And that's one of the breakthroughs that on the Accelerator side, from my colleague Sami Tantawi.
Because you can't take a 2-mile accelerator around the world. So you obviously need to turn that accelerator into something. Is that going to be technically possible to get those kinds of energies in smaller devices?
We believe that the entire system that we're developing will end up being able to fit into a standard cargo shipping container.
Okay.
And be powered by solar power and batteries. So really a portable solution.
Now, how do the companies that build these? So you make the inventions, you make the protocols. There has to be some industrial interest that kind of scales it and makes as many as are needed. How do they think about these markets where perhaps the levels of income are not as high, the ability to pay? It seems like there's some real challenges in getting high-tech innovations out into the developing world.
Yeah, that is definitely a challenge. But I think there are resources, at least to some degree, to pay for cancer care. There are initiatives to do that. That needs to be worked on, from a health policy angle as well.
I would imagine there might be some foundations who would take a particular interest in this.
Yeah.
And also there has been, I've noticed a tendency sometimes for things that you design for robust deployment in the field actually become useful even at home.
Exactly. And I think that's the key thing. It's like, your cell phone. It's burying the complexity. You had a supercomputer in your pocket that even kids can use, right? And yet that power is something that's very relevant to all of us every day. So, in fact, the ultimate machine for Africa or other underserved areas in the world is exactly what I would want to use in my clinic.
Thank you for listening to The Future of Everything. I'm Russ Altman. If you missed any of this episode, listen anytime on demand with the SiriusXM app.